Dr. Chapman, we're going again.
Yes.
So previously we
Take
did,
three.
yes, take three. Previously we talked about, your previous past and sort of
My
more or
previous
less
past?
your
Versus-
past.
Okay.
We talked about your past.
Yes, yes.
And sort of the start of the industry that is chiropractic,
Yeah.
and more specifically what you do. Now I kind of want to talk about more in line with your clinic, because
Right.
I haven't been here since the beginning. So I'm going to throw you for a curveball because I know I gave you the questions beforehand, but I'm going to throw you for one. What was the process of starting that clinic? What was the first hurdle and the first sort of reward you saw?
Are we winding back 3 decades, or are we?
I mean, when did you start it? Like, when did you start the Lift Clinic?
We have evolved since our initial clinic. My initial clinic was a very small little clinic that, I got pretty scrappy to get some of the basic rudiments of equipment together, my X-ray machine and my tables and so forth. But, that has developed into this kind of like wonderful space that we have here with all of the latest and greatest high-tech equipment and diagnostic equipment and treatment equipment here. And so I started this venture in the end of 2019, like literally the end of 2019, which was the beginning of COVID. And so we found this beautiful space, beautiful views with lots of openness. But for the previous 10 years, we had really been trialing the combination between the upper cervical work and the intraoral appliances. And early in the early 2010s, in 2012 and 2013, we did, a colleague of mine and I did a study, a case series study on patients who had an intraoral appliance alongside of the upper cervical adjustment, or the TAP procedure. And in that article we published in 2012, we coined the term TAP, which stands for transdermal atlas positioning, which I'm sure we'll circle back around to
Yes, we will.
later in this presentation here. But we saw that there was a synergistic effect to the alignment of the head and the neck and the repositioning of those vital structures at the craniocervical junction, and the ability of that area to maintain or retain the alignment, which has always been the holy grail of upper cervical doctors, is to, we focus on putting it there, but the real problem is keeping it there. So the Lift Clinic was built with the motive of not only repositioning the atlas and reorganizing the head and the neck junction through the TAP procedure, but also onboarding and utilizing the intraoral stabilization technology.
Yeah.
So it was scrappy in 2020.
Yeah. What did you expect people, like when you first started? What do you think people? If I were a new patient walking into your first clinic that you made, what am I to expect? What was the process at first that you started?
Yes. So we had a very similar, like the core ideas of what we wanted to look at were very similar. We had the idea that we were going to, that individuals, because it was a combination and an innovation of previous technologies, we thought that we would give them a nice exposure to certain aspects of that technology, and we did so without charging. So we would set up a consultation, and we would kind of like market to specific symptoms. Those have remained very targeted. So migraines, TMJ, sleep apnea, areas of interest and areas that we're quite good at resolving. And we would do a similar posture assessment. We would do some of the neurological testing that we would do to kind of help determine that. And then we would, if they had all of those qualifications, or if they kind of met that criteria, then we would schedule them back and do a CT scan of the area of interest.
interesting.
And so we wouldn't actually do it as we do it now, where we actually go forward and we extend that offering of, of the full CT.
And then, you
It's always
actually
been
showing the twist and everything like
Yeah.
that.
We've always had to grapple with some of the challenges because we have kind of a narrow focus. We focus on certain symptoms, and we're quite good at resolving those symptoms if those symptoms arise out of a common or a specific, objectively measurable problem. And unfortunately, to really get down to brass tacks and identify that problem, we need to step forward and go forward with imaging.
Right.
And so about a year in, having survived that first year of COVID, and actually we flourished during that period of time, actually. We decided that what we would do is we would add and we would give the opportunity to our patients, once they met a certain clinical criteria, they had certain symptoms and certain findings from the physical exam part of this, that we would actually go forward and generously give them take a CT scan and then spend the time to interpret that. And so what we
would you say that's the biggest change you've done since then?
I would say so, yes.
Yeah.
That and actually onboarding a dentist in our protocol instead of just resourcing out into the community of dentists that were available to work with us, and usually it was the person's dentist.
Or willing to work with you.
Willing to work with
Yeah,
you, willing
that
to
was...
see that the bite and the teeth were a big part of not only the problem, but they were also part of the equation of stabilization and giving the work that we do with our TAP procedure some longevity and some staying power. It was very difficult to speak, that language to a dentist whose whole professional universe is teeth or a tooth, and so we kind of realized that the higher offering to our patients would be to onboard a talented dental professional who thinks about the teeth in sort of more than just the community of other teeth in the mouth, but kind of looks at that with a great deal of training from us and orientation and teaching, that look at the teeth and the bite in the context of the whole body.
Right.
And so that has been an effort. And so out of that, really came a nice curriculum for teaching dentists how to think about the teeth as something more.
Well, not only that, but we're also teaching people, kind of, it's weird, but almost like a structure of like what's more important in your body first, right? Because I know we have people come in, we're like, hey, and they're like, I want to get this dental thing done. There's some things that's like, crowns, like we do need to capture bite, so get that done. But like there are some things where we're like, wait, hold on, because this base thing that you're working with, that's going to have to do with everything that you're wanting to change, we like get that done.
Yes.
That's foundational, I would say.
It really is, and understanding that process has been a kind of a cumulative learning experience for all of us, especially for me.
So was that something you didn't know at first? Was that something that you didn't even think of?
No, I had no idea that the bite and the upper cervical spine were so intimate related until about 2011, and but I always had a clue. Early on in my very first practice, one of the things I would observe as we would reposition the head on the neck and open that craniocervical junction up, and the patients would feel it immediately. They would, same effect really as now, they would sit up on the table and they would, after the procedure was done, and they would breathe better.
Right.
Big clue. They would, their posture changed, their shoulders would, drop back and down, their head would be more upright. And these were things I was observing, but
Mhm.
then a very, very common finding that they would say to me, they would kind of do that, feeling some of the nuances and the magnitude of those changes up there, and they would say, but my bite feels different. And so my first thought was, as a physician, above all, do no harm, I was thinking, and my inner thought was, oh, did I mess up their bite?
Right.
I didn't even
right.
really conceptually understand the sophistication and nuances of what the simple thing like a bite was, bringing one's teeth together. So incredibly complex, functional, neurologically, and so forth. And so what would happen is I would just like mentally note that, and I would actually physically note that in their chart. And so on their follow-up visit, 3 days or a week later, I would ask them about their particular symptoms, which were headaches, migraines, neck pain, radiating pain down the arm, dizziness, all of these things. And my answer would go, their answer to me would go like this, generally, but almost every patient. Yeah, the headaches are better, or the vertigo's way better. It started to come back a little bit. The headaches have started to return a little bit from the status of being gone or completely resolved. And so I would note that, and so my approach then would be okay, well then we're just going to redo the procedure and retap you. We're going to start this.
That's the most
Now begins our revolving door
logical
relationship.
solution,
So
yeah.
let's put it back in, because we would infer from that they had gone out of alignment and they had started to lose their what we would call adjustment. And then I would ask them, not in 100% of the cases, but I would ask them enough that it became imprinted in my memory to feel okay about it. I would say, so how's the bite? And they would say, oh, it's back to normal. And my first thought was, wow, okay, good, I didn't mess up your bite. And it took me a decade or more to kind of like
the correlation of
the
that,
correlation between the bite's back to normal and the craniocervical junction has begun to relapse. I wasn't thinking in those terms.
Wow.
Until I met a dental colleague who introduced me to some dental technology that focused on occlusion and airway and head and neck and jaw posture, and that really just exploded my conceptual world of how the jaw and the teeth and the bite began to integrate into it. And so in the early stages of understanding this, hopefully a learning, I shortened the learning curve for other practitioners.
Sure.
I started to notice that I had groups of patients, even early on. There would be those patients who we would do the procedure on, and they would hold that position or procedure better than others. And I had another group of patients on the other end of the spectrum who wouldn't hold anything. We'd put them in position, they'd feel great for a day, 2, 3, 4 days, whatever, and then they'd quickly return to their misaligned state. I would re-image them, and we'd look at their atlas, and we would see, oh wow, that's like right back to where we put it, even though after the procedure we placed it over there. It's just kept relapsing. And when you see a lot of patients, you start to profile your patients, and they kind of fall naturally into these groups. Those that would hold really well, and we maybe adjust them once, maybe twice, and they disappear. We wouldn't see them for 2 years, 3 years. And then another group that did so well, when they were in alignment, but they would relapse very quickly. And then, the bell curve, as it naturally forms with humans, most of those people would, the more we tapped them, we could kind of beat their structures into submission. And by beat, I'm talking about, with gentle little nuanced
Right, but it's enough to the
adjustments.
point where the body, I feel like, learns what it's
Yeah, it does. You
supposed
correct
to.
it enough, and it kind of gets the message. But what's very interesting is with the two end groups were the teachers. You know, these people that held and these people that didn't hold. Those are your sample that really sort of contains a lot of data that you haven't figured out yet.
Sure,
Why are
yeah.
you here and why are you here? The rest of the group kind of fits in what we might expect. And so I would have this phenomena from the group that was holding very well. I would have these individuals randomly come back in and they would say, yeah, I lost my correction. I think, wow, it's great. It's been 2 years. That's awesome.
Yeah.
And I would reposition their atlas, and they would be they'd be back in 3 days saying, you know, that adjustment that you didn't quite feel like the original one. And so I would, you know, and so I'd tap them again. So it seemed like this group sometimes would cross over and become this, they're not holding worth a darn group over here.
What do you think allowed the first? Was it just because their body maybe held it? Like, did you find anything for the first group that
Yeah.
that held it? What it was that held them for that long?
I did, and more importantly than that, I found out what it was that was causing them to shift and to move over to this other group.
Yeah.
And so I would ask them the standard questions. Well, if you had slipped and fall, if you somebody else manipulate your neck, you know, did you get in a car accident, something like that? No. And what it was is the commonality in this group transferring over into that group was dentistry. Braces. I just got done with my braces. Or I had a crown put on. Or I had a filling. I got a filling put on my tooth.
Yeah.
And that was it. And I'm like, well, that seems like, I would just like, well, that's nothing. That's trivial. That's minor.
Sure.
But these were the clues, you know, these were the clues that were building up in the practice that were there for the deciphering, for the decoding. And so that's when I started to get the nuance that that was the influence and the power of the neurology of the simple act of bringing the teeth together, changing the occlusal surface of the bite was causing the jaw, head, and neck to compensate into that adapted position to a crown or a filling or an onlay or something like that was measured in, that was balanced into their bite by a good dentist working within standards of care, but balancing that tooth in when they were laying on their back with sensory anesthetic. They couldn't feel their teeth.
Right.
And using articulating paper. You know, so these are all really not ideal environmental circumstances to balance the bite. And so the body was adapting to that.
So would it be fair to say that when you corrected them the first time, their bite probably didn't change as much, and so they were able just to hold that? There was no problem. But the minute they did dental work, huge change, and now they're in the other group where the original tap actually did have a big change to their bite.
Yeah, and so our groups now literally fall into those two categories. When we do because, you know, before we reposition the head on the neck, we now completely map out their bite using some really cool occlusal force mapping technology. And so we know what their baseline bite looks like, whether it's good or bad, or balanced or imbalanced. And the group that actually has an improvement in their bite balance tends to be more stable following a tap than those individuals who have a really nice balanced bite when their head and neck are completely jacked. And so the bite there's a greater discrepancy in that, which gets back to your original question, Owen, was there are certain dental procedures that you should wait to do after your head and neck and jaw trajectories are in alignment rather than before.
Right.
Because dentists are getting better at balancing the teeth. They're using more technology to do that. But if you bring the bite into perfect harmony and your head and neck are crooked and your jaw's compensating in that learned behavior, then when we go in and intervene and reposition that, now your bite's going to be wonky. Does that make sense?
Yeah, perfect sense. It's so weird. Every single time I go, and this is like not joking, every single time you explain something to me, it's like this little like click in my head where it's like I don't think about it because you didn't think about it. You heard
No.
people, and then something just like clicks, and you're like, oh, I can easily see how that would
Yeah.
change
Yep.
or would affect other things
Yeah.
that I've been dealing with.
Yeah.
Right? Like I know you brought me back here a couple days ago showing me posture.
Yes.
And it didn't
yes.
click to me before, but like, if you're sitting like this all nice and straight, right? And then if I go forward, you were showing me how that can open up your airway a little bit.
Yeah, just by
So-
postural adjustment.
And so your body will sacrifice your posture for a little bit more air.
Yeah.
And it's like that would make sense because
Yeah.
I think the body needs
Because
air.
hierarchically air breathing
Yeah.
and gas exchanges
And it
is
just
more
it
important.
clicked to me. I was like, oh, so when we see people come, walking down our hallway after a procedure is done, and they have straight posture. I'm like, well, now their body doesn't have to sacrifice that.
Yeah.
Their body can go back to actually relieving tension from their back or relieving
Yeah,
things,
yeah.
and it just makes sense.
Yeah.
It just
Yeah.
goes to that.
It's nice to
point.
know that there's science
Yes.
underneath all of these observable phenomena.
And I'm not joking. I keep hearing people go to the chiropractor like, yeah, they just push it back, and I'm like, great. Don't really get it. Glad it worked.
Yeah.
Glad
Yeah,
it
yeah.
worked for you. I guess it's a good segue into I think what I've heard you call multiple times your crowning achievement, which is the Equibite. Or
Yeah.
for people that are listening, it is think of like an Invisalign or a sort of. I'm not saying this is what it does. I'm just saying think of the look of like an Invisalign or a mouth guard.
Yeah.
But tell me what it does.
We'll put a
differently
little.
for
We'll
those.
put a little image in that. We'll splice a little image
Yeah.
into it here so we could see what it looks like.
Yeah, but if people
Here.
listening audio-wise, think
Yeah.
about that. That's kind of what it looks like, not super.
Yeah, it really is.
Yeah.
An Invisalign or any of those clear aligner tray systems really focus on gripping hold of the teeth and incrementally moving them into new postures. The Equibite technology that we have really is focused on the interface between the lower teeth and the upper teeth in that 3D setting, if you will. So when you reposition the head on the neck, everything else comes along with it. The shoulders, the collarbones, the scapulae, the upper ribs, everything shifts under. So the body kind of decompensates. And when it does that, all of the attachments to your lower jaw, your mandible, actually reorient themselves in Cartesian space. They reposition. And so since the origins and insertions of muscles, the insertion is on the mandible, the origin is on the collarbone and the scapula and the ribs and so forth. As those reconfigure and reorient in Cartesian space, they move the mandible through its arcs, its ranges of motion in different ways, better ways, compensated ways. And so our technology really has just captured some a way of sort of like stamping that new relationship. This I don't want to reveal too much about my secret sauce and my technology. But
Right,
we have
right.
a lot of nuanced, cool technology to just take that very sophisticated, high input system and give it a platform, a structural platform.
It's a great
that
way to
actually-
describe it.
That
Yeah.
actually really, that kind of like reinforces the new aligned position. And in a way, we trick the brain into thinking that all of the nuances of intercuspation, teeth coming together in habitual occlusion, have migrated along with everything else.
Right.
And so that's the power. And so to that one little group, that trouble group that was like, dang, I feel fantastic when my head's in alignment, but I can't hold it. Sometimes I can't hold it overnight. Well,
Sure.
those are the clenchers and the grinders that are really going at their teeth, and that habitual bite and those habitual negative patterns. We're just relapsing the craniocervical junction work we did on them. And so now we have a tool that we can give to the bell curve people and this really special little group that do so well and have so much health benefits and healing, really,
Yeah.
by having the atlas repositioned and that corridor of vitality opened up. We can now give them a platform that that's not duct tape or a collar or a halo or anything like that. It's just we recruit this whole dynamic neuromuscular system to stabilize them. So individuals with craniocervical junction instability, which is a thing, especially with trauma and injuries and so forth. So these people now don't have to go through, this roller coaster ride of being in alignment and then out of alignment and then in alignment and then out of alignment, and
Right.
so a lot of joy and happiness and healing to that group has been brought by our Equibite technology.
Sure. And for just kind of like the typical person, they come in, they do the consultation, they move forward, get tapped, we start building their Equibite. What can people expect during that process of like care?
Yeah.
What in your opinion gives them the best track of care?
Yeah. So I think that is kind of our state of the art there. So get really good at repositioning the atlas. So here, I'll give a little bit of differentiating between some of the general chiropractic procedures
Sure.
that reposition the atlas. The atlas vertebra is kind of a circular bone that rings around and is situated right in the very epicenter of autonomic function, brainstem, the area above the brainstem up into the medulla, the pons, the midbrain, all of these clusters of central nervous system structures and little centers that actually operate breathing, swallowing, heart rate, digestion, immunity, sleep. Our autonomic, our fight or flight system is woven into that little lizard brain set of stacked structures. So when you intervene in that area, be careful because you're kind of like intervening in an area that is highly vascularized. So you've got 4 big blood vessels that deliver blood into the cranial vault. 2 of those blood vessels are woven like shoelaces right into the cervical spine and make a series of right angles and bends and turns around those vertebrae. Those are the arteries that tend to be the most susceptible to dissection and stroke. So we tend to look at that area very, very, very cautiously.
Yeah.
It's rare. Those injuries are rare. They're statistically improbable. You're more likely to get hit by a car crossing a street in downtown Salt Lake. But if you're that rare individual that happens through an aggressive manipulation, it's a big statistic to you.
Right.
It's really important. So we've figured out a way to really canvas the area through a series of not only 2D images, which is kind of the convention in upper cervical care, and in chiropractic care in general, we use X-rays that look at things in 2D. We may take a view this way and a view that way and a view this way, so we may get all 3 planes in there, X, Y, Z, if you will, horizontal, frontal, and sagittal. But looking at that area in 3D is, I think, the gold standard. I think that's where you attain the highest scrutiny of the area to measure the displacements with a great deal of precision. And once you do that, because we're going to intervene in that problem, it starts with the imaging protocol. So really getting a very scrutinous perspective of how that area is malpositioned. The twist to the left, the twist to the right.
Sure.
All of those displacements are very important to measure and then quantify. And what that does for us is it lets us map out a corrective vector to intervene in with the most delicate and minimal vectored force. So the force we use to correct that area and our instrument that we use to correct that area, which is the sweat instrument. It's the orthogonal-based instrument. It has the robotic arm on it that essentially targets the atlas and the craniocervical junction and sends a slight mechanical impulse into those structures with a very, very light magnitude, but a very, very precise direction. That's the definition of vector. It has magnitude and direction.
Yes.
But that vector, if you were to take that instrument and put it on a potato chip, it wouldn't crack the potato chip.
Mm-hmm.
It wouldn't fracture an eggshell of a quail egg. But it sends enough impulse into the tissue that it will reposition those structures. We know that because we see those structures move under video fluoroscopy, which is a motion X-ray. So we know we're moving it. Here we go one step further, and we actually, after we've done the procedure, do the exam on the patient. We actually do post imaging, 3D imaging again, so we can measure all of those nuances.
I feel like that just also shows how delicate.
Yes.
The fact that that little thing
could
could make such a big difference
Yeah.
shows just how much you really do need to take care of it and
Yeah.
notice it in your life, because
Yeah.
it really does just take, that sort of thing. And if somebody's going in there and is gonna
get a little aggressive with it. And listen, it's really important I say this because, and this is not just like a medical protective disclaimer, but my chiropractic colleagues that manipulate the neck do so much good. And there's a lot of good that comes from that. But the higher up the spine you go, the more meticulous you need to be, because the higher up you go, the more concentrated are the delicate structures that guide and drive and originate function
Sure.
throughout the whole body.
Sure.
And so little changes there can essentially cause big changes in the body, for better or for worse.
Right.
So we want to always, do that on the better side instead of the worse side. So what we do for people then, these are your short
Okay.
questions, long answers. What we do for folks then is really reposition the head in the most precise and accurate way and verify that we have those structures repositioned. And then we go even one step beyond that and look at physiology, because when the airway, when the pharynx has more volume, the minimal cross-section area, the choke point,
Yeah.
is larger, we know we've got something good.
Yeah.
And that's when we register our bite.
Mhm.
That's where we do the foundational prep work to build the equibite or the stabilization appliance. After that is done, not before.
Gotcha. Okay. Got one last question for you. This is always the biggie, because we have a lot of people that settle for these things.
Yeah.
CPAPs.
yeah.
I've seen a lot of them.
Yeah.
I mean,
Yeah,
it's
for sure.
just force and air, right? I
It
mean,
is,
end of the
yeah.
day.
CPAP stands for continuous positive air pressure. So think, I got a small aperture. There's two ways to get more volume of air through a small aperture per unit of time.
Yep.
You either dilate the aperture and make it bigger, or you increase the pressure,
Yeah,
right?
Because you just start shoving even
Yeah.
harder.
Yeah,
Yep.
you increase the pressure.
Yeah.
And so we tend to, sleep, breathing, let's just say breathing, we kind of, everybody intuitively knows that breathing's important.
Yes.
It's the first thing we do. We get a whack on the backside when we come out of mama, right? And our first action is to, of course, we have to take an in-breath.
We have the APGAR test, and that's
before-
the first thing you get
Yeah.
done is literally just, how is this baby breathing?
How is the baby breathing?
That's-
And so we listen for the wail. It's probably the first and the last time we actually like to hear the baby cry.
Yes.
It's because we know if air's coming out in that primal first screech, air has gone in. So think about it. The baby
Oh.
inside a mama, they're not breathing per
Well,
se.
they're not even using most of their functions that they've just developed.
Yeah, they're not. Yeah, they're not breathing with their lungs. They're getting their gas exchange through the umbilical cord through their mom. Mom's doing all the gas exchange and just sending it down to the their unborn child through the umbilical cord. But when they come out, it's like, okay, now the breathing centers have to actually boot up, and they
That's probably why
literally
it's so
boot up.
guttural at
Oh
first.
yeah, yeah.
It's like,
It's
just
primal.
like, boom, let's go.
It's primal, and so the swallowing reflex has been sort of primed in utero, because they're sipping a little amniotic fluid, and so that swallowing mechanism is operational. But as soon as they're born, that cardiorespiratory system
Yes.
just really sort of like, bam, it goes into function. And you ask any neonatal care specialist, that's nuance. That's very important, very powerful. But it's so simple from the outside. As parents, we're like, taking the first breath, and we take it for granted. It's the first thing we do. It's the last thing we do, really. And so having this sort of like breathing mechanism, in full operational function as we go along is really critical.
Well, just showing that's the first thing we do shows how important it is for literally everything else that then goes into process as well.
Yeah. And so when we're awake, just as you first, you kind of intimated that adjusting our posture can actually open our airway when we're awake, I should say, and moving around or sitting at a desk or talking, we can make all kinds of adjustments to our posture to optimize our airway. When we're sleeping, breathing is still as important, but we're more vulnerable, where we kind of offload more work to the autonomic system. Our musculoskeletal system is less available to make those adaptive compensating changes to optimize the airway. So we tend to be more vulnerable in our respiratory centers, our breathing and sleep centers. And so since the atlas rings around that area, twists and turns to the atlas, can just gradually interfere with the optimal function of breathing, both wake and sleep breathing. And so the reason that CPAPs are so popular and really so important, really as a potential kind of brutish solution to a small aperture or an obstruction in the upper airway, which usually happens in the pharynx, is because breathing, that act of breathing, is the primary function of maintaining pH in the body. And so the body has a very, very narrow range of pH. And so what will happen, and the reason that we have developed all these means of studying breathing, we'll have a pulse oximeter that will measure oxygen saturation on the red blood cell. We'll measure respiratory effort. We'll measure, heart rate. We'll measure if air is coming in or not. So and other things. We measure some other things. With the
Well, I feel like
masseter
one
sensor.
thing that CPAP, I think a lot of people forget, is it's solving one time of the day.
Yeah.
Night.
Yeah.
And,
Yeah.
And I used to struggle with clenching during the day. I mean, you just do. I think you just.
Yeah.
I think if you have a low airway, you're just going to clench during the day, and you don't think about that.
You learn that behavior from sleeping at night.
Yeah.
Which we should really talk about.
Interesting.
Clenching, grinding, why we clench and grind at night. But
Sure,
let's
yeah.
build another segment on that. But on the CPAP machine, it does solve that problem of pushing air in through a smaller aperture. But it brings with it a host of other problems and side effects.
Interesting.
Some people think about the way a CPAP goes on or a BiPAP goes on your face. To get it to stay there, you got to put a mask on the front of the face, and you have to have straps on the back of the head. And those straps
just
have
crushing your face in.
You really compress the front of your face with the back of your head. And if you do that over time, you will actually make changes to your maxilla, your mandible. You'll compress your jaw joint up in. You'll sandwich the back of your head. And if you look at the problem as a front to back problem and you've got your airway space right here in the middle, any sort of force that compresses that is actually working antagonistically against the objective of opening up the airway.
It's like 2 steps forward, 1 step back.
Yeah, it is.
You are getting something, I guess, but you're also...
You do, and then people struggle with claustrophobia, and then breathing has this unique attribute. When we ventilate our body, it's O2 in, CO2 out. So breathing forms a wave. In, breath, out, breath. That's regulated by these little pattern generators in a little part of our central nervous system called the nucleus tractus solitarius. But the problem with a CPAP machine, less or so with BiPAP, is that it's continuous positive air. So it's always going in. Mm-hmm. And so I don't know if you, like when I was a kid, we didn't have seatbelts in our cars. So, mom could be driving down the road at 70 miles an hour. And, we put the back window down and we hang our heads out the window like dogs.
That's not the choice.
It's just we didn't know any better. Well, we did, but I mean, we didn't.
I forget how great I have it. Every single time you're like, when I was a kid, I'm like, oh boy, buckle up.
Buckle up. And so
Unintended,
what was kind of fun for me is I would hang my head out the window because that air moving by would kind of change the air pressure in the cabin of the car versus outside because of the air moving by and opening creates kind of a Venturi principle.
Yes. Mm-hmm.
It pulls air out. And so I'd put my head out the window and it would kind of take my breath away. Mm-hmm. And, I got a kick out of that. And so if you think about that phenomenon, when you've got a CPAP system on that's continually pushing air in some ways your breathing centers, which really kind of rides the wave of pressure gradients as well as metabolically, internally, concentration of CO2 and O2 gradients. On the outside, there's this air pressure, and so the ventilation system, the brainstem, kind of gets like, wait, what's going on here? I've just taken a breath in and now I'm breathing out, and I've got this big influx of air coming in.
Does CPAP doesn't regulate how much you breathe out, does it? So doesn't it have a lot to do with how much you're...
Yeah, it resists. So think about it. So when you take a breath, you got CPAP continually pushing air in. So that's really great when you inspire like that. But then now I've got to breathe out.
Half of breathing.
Yeah, that's half of breathing.
Half.
The other half is breathing out. And that's kind of breathing in is going up the hill and breathing out is going down the hill. Effort and less effort. And so now when you're breathing out, guess what you're breathing against? A resistance to that because air pressure is coming in. So we reason and hypothesize that one of the reasons why we'll see individuals who will go on CPAP with an obstructive apnea issue, the incidence of central apnea, which is the central nervous system basically stopping breathing. Mm-hmm. I think that has something to do with the inward pressure of air coming in against the stream of air going out, and the brainstem's kind of going, wait, we don't know how to push against that because breathing out is kind of like rolling downhill after you've respiratory effort to pull it in, and breathing out is kind of like so it's like lift the dumbbell, lower the dumbbell.
Well, I was gonna say, is there some case to be made that, like, because a lot of people have you do this, especially like when you're steadying yourself, breathing out is the way to really. I feel like it's kind of like that reset. I don't know. Yeah. I don't know about this, but if you're, you do it before the tap. You'll have breathe in, breathe out, tap.
Yeah.
If you're working out, you know that breathing out, you get a lot more oomph into it.
Yeah.
And I know with if you're shooting a gun or something, like you breathe out, it stabilizes everything. Yeah. Is that a fair assumption to make? Is what you're trying to say is so important?
It is. And if you break that down neurologically, breathing in, inspiration, tends to be more sympathetic, more of the sympathetic nervous system, and then breathing out tends to be more parasympathetic dominant. So, and those two, sympathetic, parasympathetic system, we can talk about that later in greater detail.
I'm definitely,
It just sort of keeps the balance of your system. And that's, the system, when we look at the body and we look at ideal functions in the body, everything functions on waves. The body is just one big conglomeration, one big symphony of waves, of, these troughs and peaks of functionality when we look, when we physiologically measure things in the body. So when we start interrupting those waveform functions, the body has to make some sort of adaptive and some sort of compensatory actions, and some bodies are more sensitive to others. And so with CPAP, I think when we step into the big room of CPAP intolerance, we find a lot of folks in there that are their system, for one reason or another, from claustrophobia on one end to I don't breathe as well, and I end up just, unbeknownst to me, unconsciously tearing it off at some point in the night. These are the CPAP intolerant. That's because I think they're intolerant to this solution of taking a small aperture and forcing more air through it per unit of time, which their body finds obnoxious. And so our solution is to make the aperture larger.
Just solve the base problem.
Instantaneously, so less respiratory effort is required from an outside machine or from the ventilation machinery.
It's natural.
Built
Your
into the
body
body.
isn't having to get used to a machine; it's getting used to itself, which is a lot faster.
And that's why folks after the TAP procedure feel almost across the board feel better rested. When we do that first follow-up visit, with very few exceptions, individuals will say, "I've slept so good." The first night after the TAP, it's not uncommon for people to say, "I slept like a baby,"
I felt so well rested afterwards. I was like, "That's sleep."
That's restful sleep.
Yeah.
And it's so important. All the research, I'm so glad we're really in the middle of a sleep renaissance. We're like understanding this
it's incredible.
mystical time. This like 1/3 of our life is kind of like domiciled into this like great unknown. Like we go to sleep, we drift off. What happens there?
Well, people forget how energized you're supposed to feel when you wake up.
People
just forget, like, you're supposed to like be ready for the day, and most people don't realize that.
It drives caffeine sales.
Coffee industry's good to get, but
I don't think we're all dealing with a caffeine deficiencies. I think we're dealing with quality of sleep deficiencies.
I agree. Yeah.
We bring, thankfully, we bring something to the table in that area, that like mystical sleep area, which is being demystified by a lot of researchers.
Yeah, it's so cool.
Yeah.
It really is. It's really just something, and you'll hear it all the time from people that come. It's hopeful. There's the hope aspect to it of like, there's solution. There is a solution to this.
Yep, indeed.
I can't get better.
Indeed.
Yeah.
Indeed.
Well, thank you.
Yeah. Thank you.
That's the next part. I guess I do really want to dive in more into the clenching and grinding, and sort of the.
We do. Just to finish up this, in our sleep study, which we do before we take on any patient, whether you're a migraine or a TMJ patient, which is a nice segue into clenching and grinding and that stress to the trigeminal system. But we do we do a kind of a baseline take-home sleep study that measures all of the, all of the elements of a healthy sleep architecture, a healthy sleep, quality sleep. We do that foundationally, and then in our process we do, especially for our sleep breathing patients, we do a follow-up sleep study to measure improvement. We never want to mess around with that, Owen, because just in kind of conclusion here, all of the known diseases and health problems, human health problems, get significantly worse in the presence of sleep apnea. And if you go to our site at theliftclinic.com and you go under our sleep apnea button, I've really kind of like targeted those and like really talked about all of those conditions. But you pull it out of your hat, you name it. Hypertension, yes. Neurodegenerative diseases like Alzheimer's, Lou Gehrig's, Parkinson's, MS, yes, all get worse in the presence of obstructive sleep apnea. Heart disease, yes. Diabetes, yes. Cancers across the board, even that, 67% increase risk in all cancers in the presence of obstructive sleep apnea. So that's why it's so important to get this looked at, to get it corrected, whether you take, I think, a higher, more elegant approach here with us, or whether you get on a CPAP machine and do it the crude old, brutish way.
Yeah.
It's important to breathe. But we do offer a more discerning, finer pathway.
Yeah,
Yeah.
more natural one too.
Yes,
that's
indeed.
for sure. I don't want to have a machine living my life.
Yeah, Darth Vader.
Yeah.
Yeah.
Well, and if you have a partner, do them a favor.
Yeah, do them a favor.
Do them a little bit of a.
Yeah. It's like, don't sleep on the couch,
Yeah.
You can sleep in the bed now. And the patient we had the other night, it's like they're putting their kids way up in the top room because, one of them snores so bad that it's like they hear it downstairs.
Yeah.
So this is, these are the warning signs. Snoring is a warning sign. Clenching and grinding your teeth is a warning sign, a big time, like nighttime bruxing. If you've gone to your dentist and you've obtained a bite guard, a Brux guard to protect your teeth, that's the tip of the iceberg. Underneath that is where the problem is. And that's usually a sleep breathing issue.
Yeah.
Reach out to us. We can explain that to you.
I know. Like when I first came in here, I was like, yeah, I got like a mouth guard, and you're like, okay, well.
Yeah.
You're just keeping your teeth a little bit okay for now.
Yeah. Mm-hmm. Indeed.
Yeah. Okay. Well, next time I think we'll go over more. I want to touch base with you and Dr. Bucks, and Dr. Bucks is a dentist.
Yes.
We've been kind of throwing in a a bit.
Yeah.
But I want to have you two sit down and genuinely get into kind of like
It's
how
a nice
you
segue
met.
into that.
And really, just the relationship. It's so It's so interesting to see.
Yes.
Especially again, I've used it a lot, but when it clicks in your brain, when you see people come in and they ask, oh, why do we have a consultation with a dentist? And we're like, well, this is it. And they're like, oh, of course. Why wouldn't we have a consultation with a dentist at that point? Know where we're at and know where we can't be. Especially with that bite. We talked about it a little bit, but
right on.
bite equilibration, really putting that bite where it needs to be. And then I know Dr. Buxton loves talking about how small our mouths have gotten.
Yeah. Epigenetically, because of our diet, nutrition, generationally, we're losing intraoral volume. Sadly, we're actually losing cranial vault space.
Are we really?
We are. First time since we've been measuring it, the cranial vault space is.
Okay.
All right.
We'll get into that more. Cut right there. I am like.
Doctor has to pee.